Welcome to day 2 of the Kansas Healthcare Coalition Preparedness Summit. My name is Danielle Martin, and I am the co-owner of Healthcare Coalition Partners of Kansas, and also the Northeast Kansas Readiness and Response Coordinator. With me is Tammy Wood, co-owner of Healthcare Coalition Partners of Kansas and Readiness and Response Coordinator for the North Central Kansas Healthcare Coalition. We would like to thank Paul and Stephanie once again for their valuable presentation yesterday. If you were unable to attend, a recording of this session will be made available on www.kshcc.com when the conference is complete. Now, let's move along to today's sessions. Today we'll provide you with the opportunity to choose a session that best represents your area of interest or response. During the first 45 minutes of the session, we will split into 2 groups. When the group pop-up appears at the end of the introduction, please simply press which option you would like to view, and you will be automatically transferred to the Zoom session of your choice.
The first choice is a session on preparing for chemical and radiological emergencies. Specifically, this session will focus on an overview of emergency response and specific measures to be taken by local communities in hazmat situations. This session is presented by Mr. Lane Sekovich. Mr. Sekovich is a graduate of Fort Hays State University and serves as the Senior Manager of Hazardous Materials for the Union Pacific Railroad in Kansas City. He has 22 years of experience with system-wide responsibility for all emergency response activities at the UP and for movement of DOT-regulated hazardous materials in Kansas, Iowa, Nebraska, and Missouri. The second choice is a session on emergency readiness in adult care homes. Dr. Jessica Kalender-Rich works for the University of Kansas School of Medicine and specializes in geriatric medicine. She is presenting on building bridges across the continuum, and she will discuss the importance of communication and collaboration across state systems of care and ways we can optimize these transitions for the benefit of both staff and patients alike. Dr. Kalender-Rich has a passion for working with facilities from a perspective of reducing rehospitalizations and improving transitions of care. Once your first session ends, you'll be automatically moved back into the main Zoom room for the last 45 minutes of today's conference. During this time, Mr. Jason Meinholt, supervisor with the KDHE Radiation Control Program, will introduce participants as to the nature of potential radiological releases and appropriate response. Mr. Meinholt has worked in the Radiological Emergency Preparedness Division of KDHE for the last 10 years. His duties include radiological emergency preparedness, radiological environmental monitoring, oversight of the Kansas Radon program, and management of the state emergency planning and community right to know program. All sessions attended in today's breakouts count toward the 1.5 available CEUs for nursing and EMS personnel. Please join us in welcoming today's presenters.
Hi, my name is Jessica Kalender-Rich, and I am a physician at the University of Kansas Health System, here to talk to you about building bridges across the continuum. So, first of all, you might be thinking, gosh, why is this random person coming to talk about the continuum? I'll just give you a little background. I am a physician in geriatric medicine, hospice and palliative medicine, and internal medicine, which means that I really take care of patients across the gamut, and that I have a tendency to really think about patients not only in the location of care that I'm seeing them, but also really across the entire continuum. And I do not have any disclosures to report, which you see right there. The other role I should have mentioned that I have that puts me kind of in a unique position to look at care everywhere is that I am the medical director of the post-acute continuum of care for the health system, which means I work with the community as a representative of the hospital and health system to try to help build those bridges, as I mentioned in our title. So I'll first start with this graphic. This is one of my favorite graphics. It's a graphic that shows the entire continuum. So you see lots of different levels of care, right? So on the left is the community-based care. That's the places that we see patients that are either pre-acute care or have gone beyond that post-acute phase. That's what you think of as your ambulatory clinics, your ambulatory surgical centers, really places that people go and then go right back home. In the middle, that very narrow spot, which frankly is the spot that medical professionals see patients the most, and it's where the cost of care is the highest, is that acute care space. And the acute care space, of course, is going to include the hospital and the emergency department, and then really everything in between. Right? And then the post-acute space is on the right, and the post-acute space is anywhere somebody goes from that acute setting. So that could be a skilled nursing facility, long-term care, assisted living. It could be inpatient rehab or LTAC, lots of things. And I'll point out that the EMS providers really are touching all of the locations across all of this graphic. Right? Whether it's taking people to or from, or working with them on site in that setting, no matter what it is, there is a touch happening there. And this graphic shows the continuum of care in this very nice, fancy, smooth, peaked continuum, right? Which we all know is not real. Because the continuum of care is actually really, really siloed, right? Not only is it siloed in location, like we've seen on the graphic, but it is siloed in actually the ability to take care of patients. And so we know that there is a non-continuous way in which people move. So people move from point A to point B to point C, sometimes back to point A, and all along that grouping. And while they move, that transitional time is the time that is the hardest for the patients, frankly. It's the hardest for their coordination, for information to move between the sites and locations of care, between the provider teams. It's the hardest time for really the care to be integrated. You know, I may make a great plan in the hospital, but how do I ensure that that same great plan happens in the ambulance on the way to where they're going? It happens in the post-acute space. How do I make sure the fourth nurse to take care of them in that post-acute space knows about all the things I mentioned when I gave report to the first nurse? Those silos are really what make transitions of care treacherous, and the reason that we need to build these bridges. So there is a lot of data out there, right, on how we are siloed. So one example is, gosh, electronic health records, they should make everything easier. But what we know is that 95% of all nursing homes have electronic health records. And this was a big change that happened in the last few years, really incentivized by a lot of federal grants and reimbursement and other requirements through the Medicare platform. That said, even though 95% of them have health records, 46%, only half of those actually can share any of that information across the health information exchange. Right, so that's a silo. I have my information, it's computerized, but you can't. And that's because of variance in software, systems, privacy settings, etc. Another study at the top of this slide I'll point out is there was a study that showed that management level organizational relationships between nursing homes and hospitals, right? So for example, the executive leadership at different locations, they may have a great relationship. They may sign contracts, they may do all sorts of things. But what we found is that does not mean that it's going to be better for the patients. It doesn't mean the transfer process is going to improve. It doesn't mean the readmissions will be better. It doesn't mean any of the on-the-ground care is actually going to be better. And these are just a few examples of patients that I have seen over the years. So, for example, Patient has goals of care. They're determined in the nursing home. EMS picks them up for some reason. EMS doesn't know they were DNR. They therefore can't tell the hospital they were DNR. Patient gets intubated, ends up dying on a ventilator. An IV access plan not communicated. Patient discharges from the hospital to a post-acute level of care. Plan was to avoid a PICC line because they're a future dialysis patient. Got to the facility somehow, someone didn't know about the plan to get a peripheral line placed. Patient turned around, got taken back to the hospital via EMS to get a PICC line, which then again was not placed. Same is true for dialysis center changes, days, times, locations, not understood across the continuum. Wound care orders. Sometimes wounds get worse in different settings because the orders are for a wound care supplier that may not be present at that site. And then lastly, and this one happens so often, is this cognitive status piece. So the baseline cognitive status of a patient may not be understood across levels of care. So I'll give you an example. I take care of patients currently in the hospital. I always call the place they came from or their family or their PCP and say, gosh, what did they look like a week ago or 2 weeks ago or yesterday? Like, what is normal for them? Is what we're looking at normal for them? Are they normally awake, talking, eating, cooking food, running the grocery store? Or are they normally staring into space, acting how they are now? And if what I've seen happen on several occasions is patient leaves hospital, taken by EMS, goes to, let's say, a skilled nursing facility. They get there and one of two things happens. One, the facility assumes that this is their baseline and isn't concerned when that's how a person is acting, and family shows up and is very upset. Number two, patient comes to the facility. The next day, the patient gets more confused. They get sent back to the hospital. Turns out they were already confused. It's just that they were more awake, so now they were more confused, or now they were moving more, so now they were at an elopement risk, or whatever it may be. These are all just examples of how that lack of information really is a challenge. And it's worsened. EMS providers, facilities, hospitals, like there are these packets that we send back and forth, right? So these packets of physical papers, which is not really a thing anybody uses anymore, interestingly. So they have this paperwork, which averages 24 pages of documentation. Now I'm going to tell you this. 24 pages is not enough documentation to know what really happened in the hospital, but the amount of paperwork it takes to know what really happened is too much paperwork for anyone to actually go through. So there have been some studies on looking at, gosh, can we prioritize the information? Can we prioritize it to include why the patient's being transferred, what their normal cognitive status is, what their goals are? For example, you send a patient to the ED from a facility, that information does not go in the packet from the facility. And then when the patient goes back to the facility, the ED also doesn't send the information back to the facility. So nobody knows what everybody's doing. And some of this is related to a game of telephone, right? So the nursing home nurse has to call the provider to tell them a patient is sick. Then the nursing home nurse has to call nursing home leadership to tell them the patient is sick. Then the nursing home nurse has to call the ED triage nurse to tell them the patient is sick. Then you hear this? Then the nursing home nurse has to call EMS to tell them the patient is sick. And then the EMS has to take that information to the ED triage nurse, which you hope is the same information. And then it goes to the treating nurse. And then it goes to the ED provider. And this is all happening while the nurse at the nursing facility is taking care of other patients. The other patients are not put on hold just because the nurse is sending somebody out. In addition to that, that nurse may not actually know the patient. The staff may be unfamiliar and not able to give a good history, which is frustrating for everyone. And when the patient gets to the ED, sometimes the ED thinks they're there for a different reason. Oh, they're there for hip pain, but really the nursing home sent them because they fell and hit their head, or whatever it may be. the information doesn't flow. And there's often not family, right? So it's the middle of the night very frequently. Family is not present either in the facility or in the hospital, so they can't corroborate that information. And all of this leads to a lack of information flowing across the continuum, and thus actually a safety issue, right? Because miscommunication of information can be a really big safety issue. So there were several studies done looking at, gosh, why can't we communicate? Some of it is different styles, right? So different people with different backgrounds are gonna communicate in a different way. Think surgeons compared to internists, or EMS folks compared to ED docs, or ICU docs compared to endocrinologists. We all have to communicate in a slightly different way. So there was this study that was done that actually looked at, gosh, can we help everyone communicate better from EMS to ED? And what they found was, in using several types of structured formats along the way, that the ED staff was actually more attentive when the clinical needs were very clearly laid out. So for example, 65-year-old lady fell, broke her hip. That's really clear. She needs to see surgery. She needs a workup. She needs to be stabilized moving forward. As opposed to what many of us have seen happen, 65-year-old lady, I'm bringing her in because she just doesn't look right. She's a little more confused. She's combative, and I don't have a definition of what's going on quite yet. So one of the more positive outcomes of this communication training was from this DMIST algorithm that's listed here. I'm sorry, one of the more negative ones, and this actually did not work. So first they looked at sharing things like demographics, mechanism of illness, injuries, signs, symptoms, and treatment already done, right? That should be kind of your basic, like, here's where we are, here's what we did, here's where we're going. And this didn't work. And they think it didn't work because it really only worked for these people that had these clearly defined needs, and also because there wasn't actually a lot of training on both sides of the patient care about how to do this. So EMS was trained how to give this information in this distinct way, but the ED teams were not trained on it, which made them not listen to the right things at the right times, perhaps. But it also, it seems like, led to less information being missed. So opportunities there. All right, so I want to talk about transferring. So if we take a step back and think about like 2020, 2021, hopefully not 2022, there was a lot of transferring happening. There was transferring because people didn't want to be in the building or didn't want to not be in the building, or who do we take care of anyone, and how do we do this? And so there were a lot of things that we saw, that we learned, and a lot of challenges in communication because of all these things that we saw. So for example, there were some EMS provider teams that just, gosh, did not want to come into a nursing facility, whether it was because they were afraid of COVID, or because they were afraid of exposure, or because they were frankly afraid that there were like 93 people out of 98 that were sick in a building, and just knew that going in meant they would be exposed and potentially sick. There was fear of entering a building. But by the way, there was also fear of letting EMS enter the building, right? There was this fear of like, we're shutting everything down. We're closing the doors. Family can't come in. Nobody can come in. EMS can't come in. We're stuck here. We're staying here. I don't want them to bring it in. And now, like, in retrospect, that made no sense, right? Because staff were going in and going out. But that's what we knew when we knew it. So they did not want to let EMS come in. Then there was the, oh my gosh, the patient got sick, send them out, get them out of my building, right? There was this idea of, if they're not in my building, I don't have cases. If I don't have cases, I won't have an outbreak. If I don't have an outbreak, I won't be on the county dashboard. So just send them out. And they would try, there were facilities that just tried to send everyone out that looked like they might be getting sick. Did that make them better? Absolutely not. Did that information get passed so that the patient got good care? Absolutely not. And by the way, were they in the right place for the care that they needed? Most of the time, no. Then there were some other guidelines, right? There were all these guidelines coming around that limited movement in the hallways because we didn't want somebody to carry COVID through the hallway to the main elevator and take the person down. How do we do this? So that's part of what one of our tools I'll share a little later we'll talk about. But like, how do we get the people to where they need to be? And then staffing, which is still a major problem everywhere, right? So because of the staffing shortages, because everyone was afraid their staff would walk if they had COVID. So that was part of it. And a lot of staff did walk. And then there were shortages. And then the shortages meant people didn't know their patients. So when people didn't know their patients, they would say, gosh, I don't really know them, but this might be different. It might not be different. They just don't look right. I don't know. And then they would call EMS to send them out. So all of this to say that we have been working really hard to communicate across those places. So what has been tried? So we're going to look at some that has been tried, some that's worked, some that hasn't worked, some that's still trying to work, and how are we going to communicate, whether it's in a future pandemic, which I hope is a very long time away, or it's in just acute care when everybody's slammed and everybody's short-staffed, or it's when we just have really complicated patients. People are getting sicker. They're getting sicker, they're getting older, they're getting more medications, more medical problems, more medical procedures. And as that happens, how do we build bridges across the entire continuum? These bridges that we saw, they have been exposed. Those of us out in the community already knew they were a problem, but now the hospitals know they're a problem. National facility organizations know they're a problem. The federal government knows there's a problem. These are all important things. These are the steps we need to help make the problems better. And COVID, fortunately or unfortunately, exposed a lot of that. So some things that have been tried first. You know, if we all have electronic health records, why wouldn't we all just be able to see each other's electronic health records? That should surely, intuitively, it just seems like it should work. That should help. So there was a look at, gosh, if we have a portal where every SNF can see the hospital's records and vice versa, does that improve transitions? And the answer is no. The answer is no, probably, because you have to look at the other person's information and know how to work it and know where to find it and know what your password is, et cetera, et cetera. Another thing that's been tried, which sort of worked, was, gosh, what if we got the same electronic health record for a lot of different places, and we have an information, we compare that to a health information exchange, which is where everybody just sort of dumps their data into one place. And there was some marginal improvement with the use of one electronic health record, probably overcoming what happened on the previous study I mentioned, which was, gosh, I don't know how to work 45 electronic health records. I only know how to work mine. And if it's yours, then you know how to find stuff in it. I mean, I can't even tell you how many times I help train people that I have trained before how to use the electronic health record that we share from my health system online to specific providers. Because if you don't use it all the time, you don't remember. Other things are this continuity assessment records and evaluation item set. So this is this like really standardized tool for, I'm discharging somebody from the hospital to the post-acute level of care. And I want it to include all this stuff, which is information on their medical needs, their functional baseline and current status, their cognitive status, their social support, right? It looks at their prior function, their medications, wounds, their BIMS, which is their cognitive assessment, their CAM, which is their delirium assessment, pain, bowel, bladder, et cetera, et cetera, et cetera. Think of how much information is in this thing. And it was used really for data collection and comparison, and less so used for like individualized patient outcomes. But it is out there and it is standardized and it is from CMS. And some of it is incorporated into the required data collection that facilities do. Sorry. All right. So other forms that have been used for transfer are, this is a universal transfer form. So this is from AMDA, the Society for Post-Acute and Long-Term Care. It is an extensive form. It's multiple pages. I just pulled out the beginning. I'll just point out it includes like, gosh, admitting diagnosis, other diagnoses, current diagnoses. Just imagine you're a nurse that has to fill this out. The patient's leaving and EMS is here and we have to get the information. Nobody can do this. Nobody can take the time to fill out this form, even if it has all the information that everyone needs. There's a ton of details here, really important details. Truthfully, they're the details that I want when I receive the patient in the hospital or that I want when I receive the patient in the SNF. And probably the EMS provider would love some of this information while the patient is going, especially if they have to go far. But it's hard to know what's really needed, right? It's hard to differentiate what is really needed. And then this is another form. So nursing facilities use these forms called interact forms for lots of different metrics that they follow. And one of the metrics is, of course, the transfer to the hospital metric. And that is another example of a form. This one does have something that I think will be interesting to all of you. It includes a question that basically says, like, why are you sending them to the hospital? Meaning, are you sending them because their PEG tube is clogged and they just need it reopened? Are you sending them because they fell and hit their head and need a scan? Or are you sending them because they just aren't right and they look septic and you don't have a source? Because those require totally different interventions, right? So this, the uniqueness about this document is that it has that question. And importantly, it also has, it's usually incorporated into the electronic health record for the system. So because they have these interact forms typically built into their EHR, they can then store it in their EHR, which is really helpful. But again, I'll just point out, like, who has time to fill out this form when they have an emergency patient, they're calling EMS, they're doing all those phone calls I mentioned earlier in the talk, and they're really just trying to coordinate care while also caring for the current patients they have. That is too much. So the information we want to flow is on here. The way to actually make it flow, very challenging. So when it all comes down to it, right, any information is good information. We do not want to seek perfection and thus not be able to make any progress, right? We have to have them both. So any single source of information is helpful. Verbal is helpful, paper more so, and electronic even more so, but only if it's filled out. If it's not filled out, it's really not helpful, right? And if it doesn't have actually relevant, accurate information, it's really not helpful. And it doesn't make its way to the right people, it's really not helpful. All of these things have to happen in order to have created and provided a set of information that can help build those bridges across the continuum. So as we think about emergency preparedness, so whether it's for a pandemic or for one emergency situation or whatever it is, we know, and this became so obvious, we know we have got to have relationships and contacts at other sites. So the facilities need to have contacts at hospitals. The hospitals need to have contacts at EMS. Public health needs to have contacts at everywhere. Frankly, people that work at facilities need to have contacts at other facilities. We all need to talk. These different levels of care across that big, vast continuum have to talk. And sometimes those are one-on-one relationships. And sometimes those are at that management level I mentioned earlier. And sometimes they're like financially driven, but we have to talk. And these relationships across different sites of care really didn't exist before. So one of the things that happened during the pandemic was this development of regular communication. So for example, county leadership in some counties was sending out weekly emails, updating facilities, hospitals, home healths, etc. All this information about what's happening. There were live feeds, right? There was on television or on Facebook or on whatever social media. There were all these live feeds going on with regular communication. There was also some sharing of resources, right? And we have to do that. So, for example, in our region, we got together a group of skilled nursing facility, long-term care physicians. We got together the county, we got together hospital representation. We got together some actual facility representation from people that like owners and operators kind of people, and got all those people in a room regularly so we could share resources. Because that's what we all need to do, is be able to talk to each other, build bridges, build relationships, share successes and failures so that we can move forward together. Because frankly, the only way we could have moved forward was together. I mean, even little things. I need some gowns. Do you have a case of gowns I can borrow? Yeah, I'll get you back next week. That's the stuff we didn't have before 2020 that we have now. And we need to have. And we are all often competitors, but that doesn't mean we want to compete to the extent that it hurts our patients. So one of the things that we created actually in that task force that I mentioned was this toolkit. So this is a toolkit that was made publicly available. Actually, it was on a local website that was nationally shared and was published in a national nursing home organization manual. And it's step by step, right? And we included a former nursing home administrator to help build this because we wanted it to be able to be something useful, used, good for the patients, good for the facility, good for staff, good for everyone. And what it did is it filled a really big need with really little ways to accomplish it. So you will see this is like the front page, and I certainly am not going to go through each of these things, don't worry. But the front page includes all these different steps, whether it was like protocols for masking or protocols for vitals or how to keep track of your employees or contact precautions updates or whatever it might be. This could all be put into a notebook in a facility that anybody could access. And the piece that's most important to this group is this bottom one. It's like, when do we move the patient to the higher acuity, right? When do we do it? How do we do it? And how do we do it without causing all those things we had before? Can EMS come in the building? Can the patients leave? All those pieces we talked about. This contactless transfer tool was meant to really help with. So especially as facilities were dealing with a lot of infections and a lot of pressures and frankly, a lot of inefficiencies that were impacting the community, there was created this patient hospital transfer packet. And while it may not be as helpful for COVID-19 right now, it can certainly be applied from any other kind of person going to the ED. So what it does is it gives information. First of all, it tells you the facility name and phone number and the discharging physician name and phone number. And why do we need that? Because when they get to the next place, nobody's going to know who to call for information. This is that information. And the next piece is that transfer tool, right? So what should be in the packet? So this is a list of all the stuff that really should go with the patient in this transfer packet. So that includes, gosh, a face sheet, an H&P, any labs or medications. This is the really important stuff. And you think, gosh, it's already in the packets that I take back and forth. And some of it is, but a lot of it isn't. Nursing notes, as an example, DPOA paperwork frequently doesn't get shared. DNR paperwork frequently doesn't get shared, especially in an emergency. These are really important things because they tell the story of what's happening with the patient or the resident, so the story can be passed to the next level of care. And then the bottom of that same page includes, gosh, if all this is met, this is when you can do a contactless transfer. This is when you can take the patient to the emergency bay, ambulance bay, and stay with them or stay near them. Don't ditch them there, because they are stable. They can be moved safely. They can accomplish this with staffing that they currently have. All of those reasons would allow the patient to really get that contactless transfer, which is frankly more efficient for the staff, for the EMS staff and the nursing home staff, right? There's no reason to always have to come upstairs if you have all your information or into the building or wherever it may be. And it's more efficient for the nursing facility staff because they know exactly what to include in that transfer packet, how to get it, where to print it, and what to do with it. So this tool is really still useful because it communicates the information. What we recommend actually is that the packet is created upon arrival, maybe with the H&P, like things keep getting added so that it's ready, especially for somebody who's high risk for transfer. And what we're actually working towards, hopefully, is some standardized reports for EMS. Like what should actually go from nurse to nursing home nurse or hospital nurse or whoever it is to EMS to ensure that the right information is given to the right people at the right time for the right duration and with the right level of efficiency. And that's actually the end of my presentation. I look forward to receiving any questions that anybody might have via email. I'll be happy to answer those, or if you need anything further, just let me know. Thanks.
Healthcare Coalition Partners of Kansas would like to thank Elaine Sekovic, Jason Meinholt, and Dr. Kalender-Rich for their generous time today in presenting on chemical and radiation, as well as on adult care home emergency preparedness efforts. We do thank you for your time as well as participation today, and we would also encourage you to join us on Thursday from 12 noon until 1:30 Central, as we will be having our first annual statewide Healthcare Coalition meeting, and we will be partnering with all 7 regions to discuss our radiation annex for our response plans. We look forward to seeing you then. Thank you and have a great day.